So obesity is a medical disease which need a medical treatment. It is not a cosmetic problem. We know that lot of complications are there because of obesity. If we don't treat it, the risk of hypertension about 5 to 6 fold, diabetes is about 3 fold, hyperlipidemia 2 fold, different type of cancer, osteoarthritis almost 2 fold, and it leads to gallstone formation, it leads to fatty liver, and nowadays NFLD or MFLD and cirrhosis is the commonest complication. Sleep apnea, which even causes sudden death in few patients, low backache, impotence, infertility, menstrual disturbances in females, psychosocial issues, depression, suicidal tendencies, different type of cancer like colorectal cancer, gallbladder, breast, endometrial cancer, and cervix, hiatus hernia. And these patients, if they develop accident, the injuries are more severe than the normal people. So we need to operate just to prevent these illnesses in these people. Now, whatever we do to treat obesity, we need treatment which is a lifelong, because it is not a temporary disease or not a short-term disease. Since obesity is a lifelong disease, which need a lifelong treatment. If we talk about treatment part to treat obesity, we know about diet, which is helpful about 5 to 10% of weight loss if it is being modified for the whole life. Similarly, to lose 1 kg, you need to burn about 7,500 calories. Means somebody who is 40 kg need to burn about 3 lakh calories, which is again very difficult. A normal person can do exercise, but a person who is morbidly obese cannot do effective exercise. And if they do, sometimes they develop complication because of the weight itself, like joint pain, injuries to tendons and muscles, and they cannot continue exercise for the whole life. Similarly, medicines, last 40 years, 40 different medicines were discovered, but none of them could stay longer. We recently, last 3 years, we got newer molecules, GLP-1s and analogs, and the combination of GLP and GIP, and like tirzepatide, having a promising result, saying about say 20% of weight loss, but we need to believe that it has to be lifelong. Who can afford this medicine for the whole life? And we don't know the lifelong complications of these medicines as well. So obesity is a serious chronic disease which need a serious chronic treatment. Surgery is option for morbid obese people, and prevention is when you are overweight, we can avoid obesity. There was a consensus meeting in America in 1991 wherein they invited all the experts dealing with obesity, whether they were diet specialists, exercise experts, physicians, surgeons, endocrinologists, everybody, and it was concluding that consensus meeting in 1991. Just imagine, almost 35 years back, that bariatric surgery is the only proven method to control weight loss. It does not remove, it does not lead to removal of the fat. It is not a cosmetic surgery. Surgery is adjunctive and not curative, in the sense you need to have a modification of lifestyle even after surgery to maintain the weight. These are the indication of obesity surgery, bariatric surgery. These are the universal indications, like BMI equal or greater than 40, but in India we changed these criteria to in 2008 to 37.5 without any comorbidities, or BMI equal to 35. In India it is 32.5 with significant comorbidities, and there is documented effective non-surgical attempt of weight loss at least up to 6 months and committed to long-term follow-up. Individual risk benefit ratio need to be evaluated in every individual to offer the surgery. These are the criteria for bariatric surgery in adolescent group. Adolescent patients are only considered after failed attempt of weight loss for at least 6 months, attain an early physiological maturity. Severely obese who are more than 40 BMI with serious comorbidities are offered, or super obese who are more than 50 BMI with less severe comorbidities can be offered bariatric surgery. They should be capable or willing to come for follow-up, provided the family is supportive to follow these people. So the goal of surgery is not only to reduce weight, but also to improve the quality of life and to improve the associated comorbidities which are there, like diabetes and hypertension. How bariatric surgery works? Bariatric surgery leads to reduce appetite, reduce satiety, After alter the taste of food, restrict the intake, leads to malabsorption of nutrients, it increases energy expenditure, and certain aversion of food also effective in losing the weight. These are different type of surgeries. We have predominantly restrictive surgery, malabsorptive surgeries, and we have combination of restriction as well as malabsorptive surgery. This surgery, which was started in 1952, which is very, very old. Those days it was done by open technique, so people were not opting for it. But since 1995, it is being done by laparoscopy, and surgery can be performed in half an hour to 45 minutes to maybe maximum by 1 hour, and the person can go home on the same day or maybe within 24 hours. This was the gastric band, which was introduced almost 40 years back, um, which is not being used nowadays. It was only a restrictive procedure, putting a band near the G junction, allowing this patient. Here, patient need to go to a surgeon or doctor to get it adjusted repeatedly, and the band was causing problem because it can erode into the stomach, which leads to major complications. So this is discontinued, and nowadays we don't use. I mean, I don't think India it is available in our country. These are the malabsorptive surgery like biliopancreatic diversion, wherein we remove the distal part of stomach and joining the ileum with the stomach. Here the food capacity is significantly high, but the bile and pancreas juice is diverted to terminal ileum about 50 cm proximal to ileocecal junction. This surgery was developed by Professor Scopinara from Italy, and only his group is doing this surgery even today, which is less than 1% surgery in the world. The commonest surgery which was being done is Roux-en-Y gastric bypass, wherein we make a small pouch of stomach, then we disconnect the jejunum about 50 cm distal to DJ flexor, and then joining jejunum with the jejunum here, and the other part of jejunum is joined with the stomach pouch. So this is Roux-en-Y gastric bypass, and this is the final configuration. So one can eat small amount of food, and that will go through this route. This is called Roux limb, and this is the Y limb. That is why it is called Roux-en-Y. Another common surgery which is being done in our country nowadays is sleeve gastrectomy, wherein we reduce the stomach capacity from this size to this size, and portion of stomach is taken out. Here we have a G junction and we have pylorus, so it is a high pressure tube created in between two walls. The sleeve will increase in size, and after 3 to 4 years you start gaining weight, and that is when we have to teach this patient. The patient has to learn how to restrict the quantity of food so that sleeve will not enlarge in size. So the problem with sleeve gastrectomy, because of the high pressure, sometimes these patients, about 30% people will develop reflux, and 40% patient will come back for weight regain after sleeve gastrectomy. So I personally don't recommend and not do it, but we have modified the procedure. The another procedure is mini gastric bypass or one enhancement gastric bypass, which is being done. Here we make divide the stomach, keeping a larger pouch, and that pouch is joined with the small intestine. The diameter of anastomosis is 6 centimeters, so there is no back pressure created. It will never increase in size. At the same time, one can eat more than the sleeve gastrectomy because there is no restriction. But here, malabsorption is a major factor. So you need nutritional supplement for the whole life, and your protein intakes should be very high in these patients. I usually recommend it to those who are having more than 50 BMI and weight loss requirement is more than 50 kg. This is a combination sleeve and MGB, wherein we just join the loop here with the sleeve. So sleeve pressure is reduced by joining the stomach, the jejunum here. And this is another modification of Roux-en-Y combination. So we join the Roux limb here. So food can go through this route, to this route, and at the same time it will go through the main route also. So nothing is blind, and we have access to duodenum and the whole GI system by endoscopy. So this is the preferred surgery by me nowadays, because here we can achieve benefit of both sleeve and Roux-en-Y gastric bypass. The quality of life is good. There is no nausea, vomiting, and they can lose weight, and we can customize it according to the need. Like we can change the length of the biliopancreatic limb, and we can change the length of Roux limb depending on the requirement of their weight loss as well as the resolution of the comorbidity. And this is how it is being done. This can be done in patients like cirrhosis like this. We have significant number of patients who underwent surgery, and here these patients are not fit for transplant because of the cirrhosis and weight. BMI is too high, so we reduce their BMI by doing this surgery, and they are candidate for future transplant. And the transplant, they can even delay the transplant if we lose the weight. And this is our publication on cirrhosis in bariatric surgery by my team. Similarly, we had designed a surgery wherein we don't cut the stomach and just do the suture like this. And the problem here is because if the two valves, there is high pressure which is created, it will increase in size. So just to avoid that, we can put a loop jejunum here to decompress it, and we can achieve the similar. And this is a randomized trial which I published in 2009. This is all being done by laparoscopic. It can be done by robotics. It can be done by single puncture like scarless surgery. And these are the benefit of this surgery. This is a article published in year 2000, almost 25 years back. The results of 500 patients of root and gastric bypass, wherein type 2 diabetes is resolved in 95%, cholesterol in 97%, hypertension 92%, cardiac improvement in 95%, osteoarthritis means you can avoid the joint replacement in almost 82%, sleep apnea in 75%, and stress incontinence and GRD in 87 to 98% respectively. This is my youngest patient of 3 years who underwent surgery. She is 15 years, who has severe psychiatric problem, and now she is disease free without any treatment. Now this is when she graduated. It's 10 years. And she is 9 years, and he was 4 years 10 months. Now you must be thinking why I do pediatric patient. Look at this girl. This picture is shared by my friend Dr. Ramchandran from Kota. Look at this girl of 11 years and look at her bone. So these kids, they develop deformities because of the weight, and we need to treat them. And similarly, this boy of 254 kg with almost 100 BMI, I brought him to 84 kg. Losing 177 kg by surgery is possible. And similarly, this girl of 23 years who was 206 kg was brought to 60 kg. And this is bedridden patient of 83 years. For almost 11 months, we brought him, we did surgery, and now he is able to walk. And this is the picture after 10 years. With this, I conclude my talk, and thank you so much.